first of 3 top abstracts selected for the 26th annual meeting. Efficacy and safety of a single dose of Exagamglogene for transfusion-dependent beta-Thalassemia and severe sickle cell disease, presented by Dr. Haydar Frangoul from the Sarah Cannon Pediatric Transplant and Cellular Therapy Program at TriStar Centennial. Please welcome Dr. Haydar. Frangoul.
Thank you. Well, thank you for having me present on behalf of the study team our work in patients with the transfusion-dependent beta-thalassemia and sickle cell disease. So these are my disclosures. So we know that naturally occurring genetic polymorphisms in the BCL11A are associated with elevated fetal hemoglobin and decreased severity in patients with transfusion-dependent beta-thalassemia and sickle cell disease. BCL11A suppresses the expression of gamma globin and thus suppresses the production of fetal hemoglobin. In the mouse model, editing of the BCL11A reactivate gamma globin expression and formation of fetal hemoglobin. Exagamglogene is produced using a non-viral ex vivo editing of the erythroid-specific enhancer region of the BCL11A and CD34 hematopoietic stem and progenitor cells and reduces the erythroid-specific expression of BCL11A. Infusion of Exagamglogene leads to an increase in hemoglobin F levels in erythroid cells in vivo. We are presenting data today from 2 pivotal clinical trials, CLIMB-111 and CLIMB-121, which are multi-center international clinical trials. CLIMB-111 is a multi-center trial, enrolled patients 12 to 35 years of age with transfusion-dependent beta-thalassemia with all genotypes, including the most severe genotype of beta-0, beta-0, with historic red cell transfusion of 100 cc's per kilogram or more than 10 units of red blood cells per year. The primary efficacy endpoint for this trial is the proportion of patients achieving and maintaining an average hemoglobin of greater or equal to 9 grams per deciliter without red blood cell transfusions for at least 12 consecutive months after transplant. CLIMB-121 enrolled patients ages 12 to 35 with severe sickle cell disease and history of greater than 2 vaso-occlusive crises in the previous 2 years. The primary efficacy endpoint is the proportion of patients who have not experienced any severe vaso-occlusive event or vaso-occlusive crisis for at least 12 consecutive months after Exagamglogene infusion. We are presenting data today based on the data cut from February of 2022 on 75 patients, 44 patients with transfusion-dependent beta-thalassemia, and 31 patients with sickle cell disease. The patient characteristics for the 44 subjects with transfusion-dependent beta-thalassemia included equal numbers of patients, female and male, in equal proportion, with around 60% of the patients with the most severe genotype of either beta-0, beta-0 or beta-0, beta-0-like disease, and around 40% of the patients with non-beta-0, beta-0 genotype. The mean age was 21.3 years, ranging from 12 to 35, and the mean historic red cell transfusions were 36 units of packed red blood cells, ranging from 15 to 71. For the 31 subjects with sickle cell disease, they were equally distributed between male and female subjects, with the most common genotype of beta-S, beta-S, with two subjects with beta-S, beta-0. The mean age was 22.5 years, ranging from 12 to 35 years. The historic vaso-occlusive crisis episodes per year were a mean of 3.9, ranging from 2 to 9.5. Patients, after being enrolled and screened and enrolled, they undergo peripheral blood stem cell collection that is shipped to a manufacturing facility. Then the cells are returned to the center where the patients undergo myeloablation with busulfan for 4 days, followed by infusion of the stem cells. For the sickle cell cohort, the drug product cell dose was 7.5 million CD34 per kilogram. And for the sickle cell cohort was 4 million CD34 per kilogram. The patients with thalassemia all achieved neutrophil and platelet engraftment at a median of 29 and 43.5 days respectively, with a duration follow-up of around 12 months. For sickle cell patients, the median time to neutrophil and platelet engraftment was 27 and 32 days respectively, with around 12-month follow-up ranging from 2 to 32 months. For 42 of 44 patients, 95% of the patients with transfusion-dependent beta-thalassemia treated with exa-cel are transfusion-free. So just to orient you a little bit to this swim plot, the light bars indicate, the light gray indicate the time when patients are receiving transfusion therapy, and the dark bars show transfusion independence. The dotted line that is first, let's go back, sorry. The dotted line that you see here is the 60 days after the last transfusion. This is the washout period. So 42 out of 44 patients, which is 95% of the patients, remain transfusion independent. And 2 patients had not yet stopped transfusions, but they had significant decrease in transfusion requirement of 75 and 89% in volume compared to prior to enrollment. 100% of the patients with sickle cell disease remain vaso-occlusive crisis free. With the, just to orient you here on the swim plots, the first line is the last red blood cell transfusion, and the second line is 60 days after the transfusion was completed and have a 60-day washout. So the first line is the last time they received blood, and the second line is the 60-day washout of the transfusion therapy. Patients with transfusion-dependent beta-thalassemia had an early increase in fetal hemoglobin that derived a substantial increase in total hemoglobin above the transfusion threshold of 9 grams per deciliter. And as you can see here, by 6 months with 32 patients that have six-month follow-up, the hemoglobin was 11.7, and the majority of the hemoglobin is coming from fetal hemoglobin. Just to orient you, the dark blue line is the fetal hemoglobin. The light blue is hemoglobin A. For patients with sickle cell disease, they had clinically meaningful increase in fetal hemoglobin above 20% that occurred early and was sustained over time. As you can see from this plot here, the dark blue is fetal hemoglobin, the light blue is hemoglobin A, and the red is hemoglobin S. And by 3 months, the fetal hemoglobin was greater than 30% and remained greater than 39% throughout the study period. We wanted to evaluate if the fetal hemoglobin was evenly distributed in the red blood cells, so we performed flow cytometry on the red blood cells, and by 6 months, more than 95% of the red blood cells contained fetal hemoglobin in both patients with beta-thalassemia on the left and patients with sickle cell disease on the right. And this was maintained over time. We also wanted to see if the BCL11A editing was maintained over time. Patients underwent bone marrow evaluation at 6 months, 12 months, and 24 months. And as you can see from this plot here on the left is in patients with beta thalassemia, the percent edited CD34 cells in the marrow remained constant throughout the duration. And similarly in patients with sickle cell disease without drop-off, indicating that the cells persisted over time and did not disappear. The plots below show that the nucleated cell editing in the peripheral blood, which also remained very stable over time. The exa-cel safety profile is consistent with what you expect when you use high-dose busulfan for 4 days. 100% of the patient had an adverse event primarily related to busulfan, high-dose busulfan, and bone marrow transplantation. None of the patients with sickle cell disease had a serious adverse event related to exa-cel. And here in the slide, it shows no patients with sickle cell disease died during the study. But unfortunately, after the data cut in February, there was an adult patient with sickle cell disease who developed pneumonia related to COVID-19 infection, resulting in respiratory failure. The investigator assessed the event as due to COVID-19 infection, and potential contribution of busulfan lung injury. There were 2 patients with beta-thalassemia that experienced a serious adverse event that was thought to be related to exa-cel, and I'm going to talk about that in the next slide. 1 patient with transfusion-dependent thalassemia had 3 SAEs related to exa-cel with HLH, acute respiratory distress syndrome and headache, and 1 SAE of idiopathic pneumonia syndrome related to both exa-cel and busulfan. All began in the peri-engraftment period in the context of HLH. Events fully resolved after using a brief course of immune suppression treatment. HLH is a systemic hyperinflammatory non-infectious syndrome that has been reported following autologous hematopoietic stem cell transplant. 1 patient with transfusion-dependent beta-thalassemia had a serious adverse event related to both exa-cel and busulfan of neutrophil engraftment. Both SAEs resolved, neutrophils engrafted at 56 days, and the patient did not receive any backup cells. All other patients in the exa-cel trials achieved neutrophil engraftment within 43 days of exa-cel infusion. There were no patients with sickle cell disease that had any serious adverse events considered related or possibly related to exa-cel. In conclusion, data from 75 patients with transfusion-dependent beta-thalassemia and sickle cell disease show a single-dose exa-cel, 31 patients, single-dose exa-cel leads to early increase in fetal hemoglobin and total hemoglobin that is sustained over time up to 3-year follow-up. 95% of the patients with transfusion-dependent beta-thalassemia stopped red blood cell transfusions, and 31 patients with severe sickle cell disease are free of vaso-occlusive crisis. Patients with greater or equal to 1-year follow-up had stable proportion of BCL11A edited alleles in the bone marrow and peripheral blood, indicating successful and durable editing of long-term hematopoietic stem cells. Safety profile of exa-cel is consistent what you expect with busulfan myeloablation conditioning and autologous stem cell transplantation. Exa-cel has the potential to be the first CRISPR-Cas9-based therapy to provide functional cure for patients with transfusion-dependent beta-thalassemia and sickle cell disease. None of this would have been possible except for the patients and their families. Patients really, patients like Victoria Gray that many speakers have mentioned during this conference that really signed up for these trials and enrolled. I would like also to thank the investigators, the nurses, and the entire exa-cel team and the sponsor. I'm happy to take any questions. Thank you.
Thank you very much, Dr. Frangoul. We have time for 1 question. Let's see whether we can see that.
I don't know if I can see.
Question? Probably have to
Hello.
speak up if there's a question.
What was the mechanism of delivery of the guide RNA complex?
It was electroporation of the stem cells. Is that the question? Is that what?
Question came from over there, I think.
Okay.
Did that answer your question?
Did that answer the question? I just want to make sure.
Yes. Okay, wonderful.
Perfect. Thank you so much.
Again.
Thank you.
Wonderful, yeah.
Thank you.